Hi everyone, welcome to the 70-step approach for systematic analysis of ECG. First, we will start with a case scenario. A 64-year-old male was brought to the emergency department by ambulance with history of central chest pain radiating to the left arm for past 4 hours. He did not have any significant past medical history and physical examination was normal. This is his ECG. Please pause the video to analyze the ECG yourself and see whether you can pick up any abnormality. Let us now use 70-step approach for a structured analysis of this ECG. Heart rate. First step is to calculate the heart rate. If the rhythm is regular, count the number of big squares between two R waves and divide 300 by this number. In this ECG, there are just over 4 big squares between two R waves. For the sake of simplicity, we will consider 4 squares and dividing 300 by 4, we get 60 as the heart rate per minute. But what happens if the rhythm is irregular? If the rhythm is irregular, count the number of QRS complexes present in the rhythm strip and multiply it with number 6. The way it works is that the rhythm strip is typically 10 seconds long and 10 times 6 equals 60 seconds or 1 minute. In this example, there are 22 QRS complexes in the rhythm strip. 22 times 6 is 132 beats per minute. Rhythm. The second step is checking whether the rhythm is regular or irregular. If there's any doubt, mark few subsequent R waves on a piece of paper and slide it across the rhythm strip to see whether the RR interval is regular or irregular. In this ECG, the rhythm is regular. Cardiac axis. The third step is assessing the cardiac axis. Normal cardiac axis is between -30 and +90 degrees. For practical purposes, an easy way to determine right or left axis deviation is to look at the direction of QRS complexes in leads 1, 2, and 3. In right axis deviation, QRS complexes are predominantly negative in lead 1 and positive in leads 2 and 3. Right axis deviation is seen in right ventricular hypertrophy and some form of heart block, which we will discuss later in the course. In left axis deviation, QRS complexes are predominantly negative or downward in leads 2 and 3 and positive in lead 1. Left axis deviation is seen in left ventricular hypertrophy, inferior myocardial infarction, and some type of heart block. Here in this ECG, QRS complexes are upright in leads 1, 2, and 3, and hence cardiac axis is normal. P wave. The fourth step is to assess P waves. Are P waves present and whether they are followed by QRS complexes. In normal ECG like here, each P wave is followed by QRS complex. In some type of AV block, there may be dissociation between P wave and QRS complexes, which we will discuss in later videos. P waves are absent in conditions like atrial fibrillation. PR interval. Fifth step is assessing PR interval. PR interval is calculated from beginning of P wave to the beginning of QRS complex. It is 0.12 to 0.2 seconds or 3 to 5 small squares. In this ECG, PR interval is around 5 small squares, which is 0.2 seconds. Prolonged PR interval is seen in first degree heart block and decreased PR interval is seen in conditions like WPW syndrome. QRS complex. The sixth step is to check whether QRS complex is narrow or wide. QRS complex is considered wide if width is greater than 0.12 seconds or 3 small squares. It is seen in conditions like bundle branch blocks or ventricular tachycardia. In this ECG, QRS complexes are narrow. This is an example of broad QRS complexes. ST segment and T waves. Seventh and the most important step is to determine whether there is any evidence of ST segment elevation or depression, and whether T waves are upright or inverted. For step 7, I usually start with lead 1. My approach is to inspect leads in the following sequence: 1 and AVL, then 2, 3 and AVF, which is followed by leads V1 to V6. I assess if there is any evidence of ST segment elevation or depression, and whether T waves are upright or inverted. Just a reminder that we should not ignore lead AVR, as it is the most neglected lead. In my clinical practice, whenever I analyze an ECG, I first look at this lead. As discussed in the earlier video, all waves are inverted in the lead AVR. Positive waves suggest wrong placement of ECG leads. In addition, isolated ST segment elevation in lead AVR may suggest right main coronary artery or left anterior descending artery occlusion. In our ECG, there is no evidence of ST segment elevation or depression, and T waves are of normal morphology throughout. The conclusion is this is a normal ECG. Thank you for watching. I hope you have gained some good knowledge and feeling more confident in ECG interpretation. In the next video, I will discuss how to diagnose ST elevation MI on ECG. Till then, take care and goodbye.